Hello friends, welcome to cytopathology, more importantly, the world of fine needle aspiration cytology. FNAC is the technique where cells are obtained from a lesion and a smear is made for cytopathological diagnosis. The FNAC report, which is issued within 24 hours of sampling, gives easy and quick information to the surgeon regarding the lesion that he is dealing with. FNAC has been a widely used technique for over the last 30 to 40 years because of its simple office technique, offering rapid diagnosis, economical, allowing sampling from multiple sites in the same sitting with a high diagnostic accuracy. Not only that, the FNAC material allows us to perform additional investigations like cytogenetics, flow cytometry, PCR, and even immunohistochemistry. The success of an FNAC depends on 4 fundamental requirements. Number 1, the sample must be representative of the lesion. Number 2, the samples must be adequate in terms of cells and the other tissue components. Number 3, the samples must be smeared correctly and processed. And number 4, it should be accompanied by the relevant clinical and radiological information. Let's look at the equipments that are used for an FNAC. The most important instrument is the standard disposable needle, ranging from 22 to 27 gauge. We use the 25 gauge needle for most lesions, but 27 gauges are used for vascular tissues such as the thyroid. 22 gauge needles are used for deeper biopsies. Next is the standard disposable plastic syringe, which is mounted on a chemical syringe pistol. Here we use a 10 cc plastic syringe. Small sterile containers with tight lids containing physiological saline or a transport medium such as Hank's balanced salt solution should be at hand. Glass slides. They must be dry, free and clean of grease. Slides with frosted ends are convenient for immediate labeling. Wet fixatives such as 70 to 90% ethanol in Copland's jar or a commercial spray fixative is needed. Other fixatives like Carnoy's fixative for lysing red blood cells or glutaraldehyde and 10% buffered formalin should be available if tissue fragments for EM or for paraffin embedding are obtained. Stains. We will discuss this shortly. Other miscellaneous instruments include skin disinfected swabs, sterile dressings, local anesthetic if needed, but most importantly, latex gloves and face masks is required for safety reasons. A small hair dryer is useful for dry smears by GIMSA. The patient from the waiting room is taken to the examination table. A complete clinical history must be elicited. A detailed physical examination should be done and noted. All relevant radiological investigations must be acquired. The procedure should be clearly explained to the patient to assure his or her consent and cooperation. A formal written consent may be required at least for deeper biopsies. The procedure is usually carried out with the patient supine on an examination couch in order to best expose the lesion. A simple skin disinfectant using a swab is done. Preparations as for minor surgical procedures such as skin disinfection, sterile cloth as well as sterile gloves are recommended. Palpate the lesion, fix the lesion with your fingers, stretch the skin slightly and insert the needle. FNA can be done with aspiration and without aspiration. Let's look at with aspiration. A 10 cc syringe is mounted onto the syringe holder. The appropriate needle is then fixed onto the syringe. The lesion is palpated and held between the fingers to prevent it from moving and slipping. Stretch the skin slightly and insert the needle. A negative pressure is applied in order to hold the tissue against the sharp cutting edge of the needle along the track as the needle advances through the tissue. Repetitive back and forth movement is done within the lesion in multiple directions with the negative pressure maintained. The negative pressure must be released before the needle is withdrawn. The sample contained in the needle is expelled onto a clean and dry microscopy slide using air in a syringe. Let's look at the case of a cystic swelling. The lesion is palpated, fixed between the fingers, and the needle is inserted. Fluid collects in the syringe due to the negative pressure. This fluid is expelled into the sterile container for further analysis, and a repeat FNAC is done in the residual tumor. The sample then collected from the residual tumor is placed as single tiny drops on individual slides for smearing. For the thyroid lesions, the patient is asked to lie in the supine position with the support placed under the neck or the upper back so that the head falls over, thereby causing hyperextension of the neck and exposing the lesion. The FNA without aspiration technique using the purple Hulk needle is done for the thyroid gland as it is highly vascular. The needle is inserted and repetitive movements are done in multiple directions. Care is to be taken in order not to puncture the underlying trachea. The patient is asked not to swallow and not to talk during the procedure. Smearing. A second clean glass slide is taken, and with a gentle yet firm pressure, a quick, thin, single-celled smear is made, and the slide is then fixed in ethanol. For a dry smear, the above step is repeated, but the slide is not placed in ethanol but kept outside for air drying. After the procedure, firm pressure with cotton should be applied to prevent hematoma formation. It is not always that the slides prepared are satisfactory. Sometimes the needle could have missed the target tangentially, or the needle is in the central cystic or necrotic or hemorrhagic area devoid of the diagnostic cells. Sometimes the needle is in a dominant benign mass missing a small adjacent malignant lesion, or a fibrotic desmoplastic target tissue gives a scanty cell yield. Now that we have prepared our smears, let us look at some of the stains that are used for FNAC. For air-dried smears, hematological stains such as May-Grunwald Gemsa, Jenner Gemsa and Diffquick are used. For alcohol-fixated smears, we can use PAP and H&D stains. Special stains such as PAS or diastase can be used to detect mucin, Alcian blue for mucin, Prussian blue for iron, Mason Fontana for melanin, Grumeliase for argyrophilic granules, and Congo red for amyloid. FNAC is associated with relatively few complications. Number 1. Hematoma. Bleeding from the puncture site and hematoma formation are the most common complications. Firm finger pressure for 2 to 3 minutes immediately after the procedure greatly reduces the frequency of these complications. Number 2. Infection. 3. Pneumothorax. Transcutaneous aspiration of the lung causes pneumothorax. Most resolve spontaneously, although intercostal intubation may be required. Number 4. Dissemination of the tumor via lymphatics and blood vessels following FNAC is a theoretical possibility. In routine practice, FNAC is most often used for diagnosis of palpable mass lesions in the breast, lymph nodes, thyroid, salivary glands, abdominal lesions, and even testicles. Other sites and lesions accessible to FNAC are the prostate, pelvic organs, bone and joint spaces, lungs, retroperitoneum, and orbit. Although FNAC has proven to be advantageous, there are a few limitations. In terms of tissue architecture, it is seen that it is better preserved and observed in histopathological sections. FNAC cannot detect capsular invasion and lymphovascular invasion. It is difficult to differentiate in situ versus invasive carcinomas in FNAC. While FNAC is generally a safe procedure, precautions have to be taken when aspiration is contemplated of some sites under certain circumstances. Bleeding disorders. Thrombocytopenia per se is not a contradiction to FNAC. In patients with coagulopathy such as hemophilia, aspiration of joint spaces, chest and abdominal viscera is contraindicated. Superficial lesions may be aspirated and pressure applied to the puncture site for at least 5 minutes following the procedure. Liver. Estimation of prothrombin time is an essential prerequisite for aspiration of the liver. FNAC is not advisable if prothrombin index is less than 80%. Obstructive jaundice is a relative contraindication for FNAC on account of the risk of bile peritonitis. Lung. FNAC of the lung should not be undertaken in elderly patients with emphysema because of the enhanced risk of pneumothorax and in patients with pulmonary hypertension because of the risk of hemoptysis. FNAC is contraindicated in acute pancreatitis as it aggravates the inflammatory process. Transrectal aspiration in acute prostatitis may cause bacteremia or septicemia and is contraindicated. Aspiration is extremely painful in acute epididymoorchitis and should be deferred till such time the acute inflammatory process subsides. FNAC of a suspected pheochromocytoma is inadvisable as it may sometimes provoke extreme fluctuations in blood pressure.